Hello, everyone. My name is Ricardo Romiti, and I'm a dermatologist at the University of São Paulo, Brazil, and I'm a board member of ILDS. I'd like to welcome you all to our webinar entitled Advancing Psoriasis Care, which I'll be coordinating today with Dr. Tammie Ferringer. This webinar is part of the Education Committee of ILDS, chaired by my dear friend, Dr. Hashimi. For the first part of this webinar today, I'd like to invite Dr. Choon. Dr. Siew is a consultant dermatologist and associate professor at the University of Malaysia, who will be giving us an update on generalized pustular psoriasis, followed by a talk by Dr. Cordoro, professor of dermatology and pediatrics at UCSF Pediatric Dermatology, giving us a talk about what's new in pediatric psoriasis. Dr. Choon, the word is yours.
Hello, I'm Choon, Associate Professor at the Clinical School in Johor Bahru, Monash University, Malaysia. I will be sharing a concise update on generalized pustular psoriasis, or GPP. We will cover evolving classification, pathogenesis, and therapeutic landscape. Recent advances have significantly changed how we diagnose and treat GPP. These are my disclosure. GPP is a rare, life-threatening autoinflammatory disease characterized by recurrent flares of painful erythema with sterile pustule. Flares are often accompanied by systemic symptoms such as fever, malaise, and fatigue. Typical laboratory findings are leukocytosis with neutrophilia and elevated CRP. GPP can result in serious complications such as sepsis and organ failure. A recent systematic review involving 35 studies and 6,000 GPP patients documented an overall mortality of 9.2%. Until recently, there was no international consensus on GPP's definition or diagnostic criteria. Erasmus defined GPP as primary sterile macroscopically visible pustule on non-acral skin, excluding cases where pustules are restricted to within psoriatic plaque. GPP can occur with or without plaque psoriasis and may present with or without systemic inflammation. Diagnosis requires either a relapse or persistence of over 3 months. In Japan, a definitive diagnosis of GPP is only made if the disease is recurrent with associated systemic symptoms and histologic confirmation. Erasmus does not mandate histology or systemic symptoms for diagnosis. The absence of universally accepted definition and diagnostic criteria has hindered timely diagnosis, treatment, and comparison of clinical data globally. In 2024, the IPC established an international consensus on GPP's definition and diagnostic criteria using the modified Delphi method. Given GPP's rarity, the consensus was based on expert review of 69 challenging real-world cases from 24 countries rather than a traditional literature review. IPC defined GPP as a systemic inflammatory disease characterized by cutaneous erythema and sterile pustule. It can occur with or without systemic symptom, laboratory abnormality, or other forms of psoriasis. GPP may manifest as an acute form with widespread sterile pustule or as a subacute annular variant. The key diagnostic criterion is macroscopically visible sterile pustule on an erythematous base, not limited to acral region or within psoriatic plaque. Supporting criteria include clinical features like leaks of pus, painful skin, fever, fatigue, laboratory abnormality, consistent histologic finding, and the presence of known risk alleles. A history of recurring flares and a personal or family history of psoriasis also support the diagnosis. Annular pustular psoriasis, or APP, is accepted as a variant of GPP due to its similar presentation of painful pustular lesion despite its annular shape. Moreover, APP may evolve into GPP, and annular pustular lesions are common post-flare manifestation of GPP. Psoriasis with pustulosis, defined as pustule within psoriatic plaque, should not be classified as GPP. This phenomenon is transient and occurs in constitutionally well individuals representing unstable plaque psoriasis rather than GPP. Pustular lesion can appear on acral region during GPP flares and should not rule out a diagnosis of GPP. GPP can be diagnosed upon first presentation. The duration and extent of pustule is not required for diagnosis. GPP is a life-threatening disease. Therefore, diagnosis should not be delayed by any predefined duration or extent of pustulation. While skin biopsy is not mandatory, it is strongly recommended to confirm GPP and rule out common differential diagnoses such as HF, pemphigus, and subcorneal pustular dermatosis. However, treatment should not be delayed while awaiting biopsy results. 40 to 60% of GPP patients also have plaque psoriasis, and about 30% have associated arthritis, as these conditions share common immunologic pathways. Plaque psoriasis and GPP share key inflammatory cytokines including IL-17A, TNF, IL-1, IL-36, and interferon. However, the expression level of this cytokine differs significantly between the two diseases. GPP lesions exhibit higher level of IL-1 and IL-36, but lower level of IL-17A and interferon when compared to psoriatic lesion, suggesting that IL-1, IL-36 inflammatory axis is the key driver of disease pathology in GPP. Genetic studies support the central role of IL-36 signaling in GPP, with IL-36RN mutation found in 20 to 80% of patients. IL-36RN encodes for IL-36 receptor antagonists, which regulate the pro-inflammatory effect of IL-36. Loss of function mutation in IL-36RN lead to abnormal IL-36 receptor antagonists, which fail to inhibit IL-36, promoting uncontrolled inflammation, leading to the clinical manifestation of GPP. Mutation in other genes linked to the IL-36 pathway, namely CUP14, AP1S3, SERPINA3, and myeloperoxidase, are also associated with pustular psoriasis, further supporting the crucial role of IL-36 pathway in the pathogenesis of GPP. Notably, IL-36 is upregulated in all GPP patients, even in those without this mutation. IL-36RN mutation showed geographic and ethnic variation. It is more common in Asians. Study linked this mutation to more severe disease characterized by an earlier disease onset, higher systemic inflammation, increased frequency of flares, and hospitalization. Mutated patients are also less likely to have associated plaque psoriasis. In Asian population, the C115 plus 60-C mutation is most commonly reported, and it is associated with geographic tongue, which could serve as a potential marker for IL-36RN mutation. Patients with this mutation may need closer monitoring and be prioritized for targeted therapy. This brings us to the exciting development of IL-36 directed treatment. 3 IL-36 inhibitors, spesolimab, imsidolimab, and ribociclib, are in clinical trials. Spesolimab has already been approved in many countries for treating acute GPP flares and for flare prevention in some regions. Imsidolimab has shown promising phase 3 results and is likely to be the next addition to our therapeutic armamentarium for GPP. Additionally, IMG 008, a long-acting IL-36 inhibitor, has demonstrated strong efficacy and longer half-life than spesolimab in preclinical study, and is gearing up to start phase 1 study for GPP. Now let's look at the pivotal FECA1 study, which evaluated spesolimac's efficacy in treating acute GPP flares. In this trial, 53 patients with moderate to severe GPP flares were randomized to receive either IV spesolimac 900 mg or placebo. The primary endpoint at week 1, a very early time point, was complete pustule clearance, defined as a GPP-GA pustulation score of 0. And the key secondary endpoint was GPP-GA total score of 0 or 1, meaning clear or almost clear skin. After just one dose of IV spesolimac, rapid improvement was observed. At week 1, 54% of patients receiving spesolimac achieved complete pustule clearance compared to just 6% in the placebo group. Additionally, 43% of spesolimac-treated patients achieved clear or almost clear skin compared to 11% in the placebo group. The speed of pustular clearance was really impressive. Complete pustule resolution was seen as early as 1 day after IV spesolimac, and clear or almost clear skin was seen as early as 2 days. And now there is increasing real-world data from case report and case series highlighting spesolimac's rapid effectiveness in resolving acute GPP flares. And here you can see that spesolimac was significantly more effective than placebo in patients with and also without IL-36RN mutation. However, patients with IL-36RN mutation were more likely to achieve both primary and secondary endpoints, suggesting that spesolimac may be particularly effective in this group of patients. Complete pustule clearance was achieved in 87% of mutation-positive patients versus 42% in those without mutation. And clear or almost clear skin was observed in 75% of patients with mutation compared to 28% in the non-mutated group. The number of patients with mutation was too small for meaningful statistical analysis, although a subgroup analysis showed no significant difference in efficacy for patients with and without IL-36RN mutation. However, this finding do suggest that IL-36RN mutation status may serve as a predictive biomarker for enhanced response to spesolimac. And in Taiwan, spesolimac is only approved for patients with mutation. Spesolimac demonstrated an acceptable safety profile with a slightly higher infection rate compared to placebo. Notably, anti-drug antibody were detected in 46% of patients, 20% of whom had neutralizing antibody. However, this did not impact the drug's efficacy. FECA2 is a flare prevention trial in which 123 GPP patients in remission with clear or almost clear skin were randomized to receive different dosing regimen of subcutaneous spesolimac or placebo. And here you can see the high-dose spesolimac group demonstrated an 84% reduction in flare risk compared to placebo over a 48-week period. And remarkably, no flares were observed beyond 4 weeks in this cohort. And over the 48-week study period, only 10% of patients in the high-dose spesolimac group experienced a flare, compared to 51% in the placebo group. This compelling and durable efficacy led to FDA's approval of high-dose subcutaneous spesolimac for flare prevention in GPP patients aged 12 years or older. There is no real-world data yet, but subcutaneous spesolimac has been transformative for some of my patients. 4 of them who have suffered from frequent GPP flares for 10 to 20 years have now maintained clear or almost clear skin for nearly 4 years with this treatment. And here you see images of one such patient, a 21-year-old man who was first admitted for a severe flare when he was only 8 years old. Since then, he had multiple flares and hospitalization due to inadequate response to available treatment, including ustekinumab. He was too young to be recruited into the FECA-1 study. However, after a flare in early 2020, which was treated with ustekinumab and maintained with methotrexate, he was enrolled into FECA-2 study, and he has enjoyed clear or nearly clear skin for 4 years. Now let's briefly discuss imsidolimab. In the Gemini-1 study, 45 patients with moderate to severe GPP flares were randomized to receive either 750 or 350 IVs in the imsidolimab or placebo. The primary endpoint was a clear or almost clear skin at week 4. Responders were re-randomized to receive subcutaneous imsidolimab 200 mg or placebo every 4 weeks for 24 weeks in Gemini-2 study. 53% of patients receiving either 750 or 300 mg of IV imsidolimab received clear or almost clear skin compared to just 13% in the placebo group. Importantly, all 8 responders on subcutaneous imsidolimab maintained their response without a flare. In contrast, 63% of responders re-randomized to placebo experienced a flare. The safety profile of imsidolimab was favorable with low infection rate and no serious adverse event. Only 3% of patients developed anti-drug antibody. And among 13 patients with IL-36RM mutation, 66% achieved clear or almost clear skin at week 4 compared to 27% of those without mutation. This again suggests that IL-36 inhibitor may be particularly effective in patients with IL-36RM mutation, and this also reinforces the potential role of IL-36RM mutation status as the predictive biomarker for enhanced response to IL-36 inhibitors. In closing, here are the key takeaways. GPP is a distinct, life-threatening autoinflammatory disease that requires timely recognition and intervention. The recent IPC consensus definition provides a clearer framework for diagnosis and classification, improving global consistency in managing the condition. IL-36 signaling is central to GPP pathogenesis, whether or not genetic mutations are present. And targeted IL-36 therapy, particularly spesolimab, are transforming the management of GPP, offering rapid flare control and prevention. Genetic insight, particularly IL-36RM mutation, may guide personalized treatment. Ongoing clinical trial and real-world data will continue to refine our understanding and approach to GPP treatment. With that, thank you for your attention.
I'm going to talk to you today about systemic therapy for pediatric psoriasis, approach to clinical decision-making. I have no conflicts of interest. I'm going to address 3 main questions today. Why use systemic therapy in children? Who is a candidate for systemic therapy? And which therapy for which patient? First, why use systemic therapy in children? We select systemic therapy when the disease is severe and uncontrollable with topical therapy or combination topical therapy or other modalities. When there are comorbidities and medical risk factors that could put the patient at risk. When there is physical discomfort and disability, unable to be managed in other ways. And certainly for psychosocial impact, when a patient is experiencing shame, bullying, social isolation. These are times when systemic therapy may be called upon to treat our patients. Psoriasis occurs in patients of all ages, and all ages of patients can get all types of psoriasis. For some, psoriasis is simply a nuisance. For others, it can be a very high burden chronic disease. Psoriasis might remain consistent in subtype or change over time in an individual patient. The condition can wax and wane in its severity, and it toggles between a chronic disease and an acute emergency in some cases, particularly in children with pustular psoriasis. It's important to evaluate all patients for comorbidities, the most important of which are obesity and metabolic syndrome, arthritis, and psychiatric and neuropsychiatric disorders such as anxiety and depression. Ideally, we would screen with a history and physical exam and use lab tests only if indicated based on the results of our history and physical. We want to seek integrated care for comorbidity management, such as referrals to a rheumatologist if appropriate for psoriasis, or to a psychiatrist or therapist for mental health conditions. When a systemic therapy is deemed to be necessary, there are many options available. And often there's no single right answer. We base our decisions on the clinical context of the patient in front of us. We also base it on family preferences, access to various medications, and other local logistics. Who is a candidate for systemic therapy? Rather than the outdated notion of mild, moderate, or severe, or calculating a PASI score in the clinic, a more clinically relevant method to determine whether or not a patient is a candidate for systemic therapy is to characterize the extent of the condition and the impact. And that means not only objective measures, but patient-oriented subjective measures such as discomfort, pain, impact on quality of life. We want to consider the body surface area, of course, but also the sites of involvement. Are they in areas such as the groin, which is very uncomfortable, or the face, which is visible, or the hands that limit physical function? We want to think about response to prior therapies and always the risk of the medication versus the risk of the condition that we're treating in the overall context of the clinical benefit for the patient. Now, in children, we always want to look for infection, particularly before committing to a systemic therapy. There's the most data for pharyngeal and anogenital strep, so that should be sought and tested. If found based on culture, then an oral antibiotic or topical antibiotic in some cases is appropriate before committing the child to systemic therapy. But also, we want to look for viruses. Viral infections in children, particularly those with a genetic predisposition towards psoriasis, can have a psoriasiform eruption, such as this one that was associated with an upper respiratory infection in this 3-year-old. Over time, a matter of a few weeks and some conservative topical therapy, this child cleared without the need for a systemic agent. Which therapy for which patient is one of the most difficult questions we have to address as physicians. And there are many tools available. There are the conventional therapies, such as methotrexate, the most commonly prescribed drug in the world for children with inflammatory skin disorders, including psoriasis. Cyclosporin, acitretin, even phototherapy as a conventional treatment. These are all relevant in certain cases. There are certainly targeted narrow-spectrum therapies, such as our biologic agents, the PDE4 inhibitors, and other small molecule inhibitors, such as TYK2 and JAK kinase inhibitors. Not quite yet to market or approved for children with psoriasis, but the small molecule inhibitors, such as the JAK inhibitors, are in studies now. There are also a number of adjunctive therapies that should be considered in individualized cases, such as antibiotics, as mentioned, for strep infection. Tonsillectomy is rarely done, but there is a subset of children who have numerous 6 or more strep pharyngitis cases associated with flares of their psoriasis, and they may be carefully selected for tonsillectomy. Nutrition, activity, stress reduction, these are incredibly important holistic approaches to children with psoriasis, particularly those who are obese or with other components of the metabolic syndrome. There's little comparative data to guide decisions between therapies, and all therapies may be relevant considerations in individual cases. The tried and true systemic therapies, as listed here, are accessible they're affordable. There are decades of experience with these medications, and they remain incredibly relevant in the US as well as many parts of the world. The drugs listed here, with the exception of phototherapy, require lab monitoring, which can sometimes be a barrier in very young children. Methotrexate is a great choice for all types of psoriasis because it can be slow onset, but a sustained benefit. This is a trusted therapy with decades of experience. We reserve cyclosporin in children as a rapid rescue medication to gain quick control of either rapidly moving plaque, gut tape, or pustular psoriasis. The problem with cyclosporin is once the dose is reduced or the drug is stopped, there can be a rapid recurrence of the psoriasis. Acitretin is an oldie but goodie. It's a non-immunosuppressive choice, which becomes very relevant in a certain subset of patients, although we do have to be careful about persons of childbearing potential, given its teratogenicity. As always, phototherapy is good if you can get it. When it's available, it can be an outstanding treatment for plaque and gut tape psoriasis, particularly narrowband UVB. The advantage of the systemic therapies and phototherapy is that they're easy on, easy off. You can combine various medications in this group, and you can even combine these medications individually with biologic agents. I always caution about the risk of immunosuppression with multiple agents and certainly organ toxicity. Retinoids plus narrowband UVB happen to be an outstanding and synergistic combination that can really help children with gut tape psoriasis or even gut tape and very early pustular psoriasis. 3 months after treatment here, you can see the outstanding improvement. This is a patient who was treated with retinoids initially with some benefit, and then low-dose methotrexate was added for the palmoplantar psoriasis. This patient ultimately ended up on a biologic therapy, but these are some more traditional treatments that we can use for palmoplantar psoriasis. We are certainly in the era of targeted therapy. The biologics and small molecule drugs are highly effective. They have a selective mechanism of action. And the expectation with these medications is complete or near complete clearance. The biologics have reassuring safety profiles. However, they're very expensive and they have extremely limited access in many parts of the world. Drug selection in this domain of treatments is context dependent. There are certain times when certain agents in this category are very useful, and there are certain contraindications. For example, we wouldn't use an IL-17 inhibitor in a child with inflammatory bowel disease. Some of the important considerations when approaching systemic therapy for children with psoriasis is the mechanism of action of the therapeutic. Is it immunosuppressive or is it immune modulatory? And this might matter depending on the clinical context. Lab monitoring. Is there a little bit of monitoring? Is there a lot of monitoring? And what will that look like for the patient in terms of blood draws? Is there an oral formulation? Is it only a tablet? Can the patient take a pill? Does it exist in liquid form? Or does the medication only administered as a shot, which may be favorable or, depending on the patient, may be a barrier? What about the logistics? Is the drug even feasible? Is there access? Can the patient even get, for example, to a phototherapy center? Or is there access to a biologic in their part of the world? How long are we going to treat? What's the duration of therapy? That is an important question to ask ourselves. Do we treat the patient consistently and over time and then taper to the lowest effective dose? Well, that's what we generally do with systemic therapies, but with biologic therapies, for example, the duration of treatment is a little trickier. Is it long-term? How do we reduce or increase the interval between injections? Is there a way to taper biologics or do we stop them? In pediatric patients, this can be very difficult, but when we put a 12-year-old patient, for example, on a biologic, we don't expect that they will need that treatment over a lifetime. However, duration of therapy is always individualized on the patient, their specific condition, and how they're responding to the drug. If a patient has at least a year in remission on a biologic, this is a time when I might increase the time between injections or try to discontinue the medication. There is some specific guidance I can offer for special cases. For example, children who have psoriatic arthritis can receive methotrexate, and in some cases they do, and this medication can work quite well. Most, if not all, of the biologic therapies are now approved for psoriatic arthritis. Some of them have to be used off-label in children, but nonetheless, biologic therapy is far superior in general for psoriatic arthritis than is methotrexate, but methotrexate still is a useful drug. If patients have CARD14-associated psoriasiform dermatitis, the anti-IL-12/23 drug ustekinumab seems to be most favored. If a patient has a monogenic form of psoriasis, such as deficiency of IL-1 receptor antagonist, then a recombinant IL-1 receptor antagonist is the treatment of choice. We now have a new drug for generalized pustular psoriasis, or patients with DITRA, deficiency of IL-36 receptor antagonist, which leads to a generalized pustular psoriasis phenotype in the IL-36 inhibitor therapy. I will say that this drug is extremely hard to get in the US and is quite expensive. Patients who have liver and kidney disease, of course, we avoid methotrexate and cyclosporin. Persons of childbearing potential, we really need to be avoiding retinoids, particularly acitretin, which stays in the fatty tissue for 3 years if it's reverse esterified to etretinate, and therefore we avoid this in persons of childbearing potential older than 9 or 10 years old. And as mentioned earlier, we would avoid an IL-17 inhibitor in patients with inflammatory bowel disease. Here is a summary of some of my favorite treatments for various presentations of psoriasis, from plaque to guttate to inverse, nail psoriasis, pustular, and erythroderma. Most importantly, when we're dealing with pediatric patients, is that we balance the risk of side effects from our interventions with the risks of undertreatment on development, the overall health, and the well-being of the child. It's very important that we take psoriasis in children seriously, that we approach the condition based on the severity and the clinical case at hand, and that we offer children the benefit of treatment that's going to control their condition and improve and optimize their overall health, well-being, and quality of life. On World Psoriasis Day, I invite us all to think about the important concept of shared decision-making, where we are taking the time to explain the medications that are available for children with their caregivers, with the child if age appropriate, and making that decision together. Thank you.
My name is Tammie Ferringer, and as co-host of this ILDS webinar, it's my pleasure to introduce Dr. Julia Lehman, who is Professor of Dermatology and Laboratory Medicine at Mayo Clinic in Rochester, Minnesota. She's going to discuss clues to differentiating psoriasis from eczema.
Hi everyone, I'm Dr. Julia Lehman, and I'm a dermatologist and dermatopathologist at Mayo Clinic. And it's my pleasure today to speak to you about clues to differentiate psoriasis from eczema, particularly on today, which is Global Psoriasis Day. So thank you to the meeting organizers. I don't have any disclosures to share, but I would ask, out of respect for the patients, please don't take screenshots of clinical photographs. So here we have a picture of a patient with pretty typical psoriasis. on the left, and then on the right, a patient with pretty typical eczematous dermatitis. And so just for review, psoriasis is usually mediated by the Th17 pathway, of which IL-17, IL-12, IL-23 are important components, whereas eczematous dermatitis is usually mediated by Th2 pathway, of which IL-4 and IL-13 are important components. But the problem comes when patients have overlapping clinical or histopathologic findings. So the patient on the left had clinical and microscopic changes of so-called psoriasiform dermatitis, while the patient on the right has generalized erythroderma. And so it's difficult to tell, either clinically or microscopically, whether these patients have disease mediated more by Th17, more by Th2, or maybe even a different pathway altogether. So you might ask, why does this matter? Well, in the old clinical paradigm, it may not have mattered as much. So here we have the Venn diagram of treatments for psoriasis and treatments of dermatitis, and you can see that they overlap quite a bit. However, nowadays, we're fortunate to have a lot of new biologic treatments, which are very precise and targeted. But with that, it's important that we know what we're treating. So on the upside, these biologic therapies generally have a very good safety profile and can be very effective. On the downside, they can sometimes cause the cytokine milieu to shift, and so you can end up with cytokine chasing. So it can sometimes be difficult to know, does the patient still have the condition they started with, or has it shifted to something else? And this was demonstrated in a recent article where the investigators looked at patients who had atopic dermatitis, and those that were treated with dupilumab are in the blue line, and those that were not, the controls, are in the yellow line. And basically, this is looking at the cumulative incidence of psoriasis following treatment. And as you can see, there's a statistically significant increase in the rate of development of psoriasis in the dupilumab-treated patients compared to controls, indicating that potentially the dupilumab, which is designed to treat the Th2 pathway, may then allow the Th17 pathway to rear its ugly head. So what I'd like to do today is give you some clues to help differentiate psoriasis from eczema. And first, we'll start out by talking about some clinical clues, move on to some histopathologic clues, and then finally some molecular clues with some new tools that we have. So let's start with some clinical clues, specifically with lesion morphology. So here we have a patient on the left who has psoriasis. You can see that there's a well-demarcated plaque that's dry and hyperkeratotic with minimal inflammation. Whereas on the right, we have poorly demarcated erythema. We've got a very wet look because of the serous changes, and also even some honey-colored crusting. Here we have two patients with inframammary rashes. On the left, psoriasis, where it's really well demarcated, but not as hyperkeratotic, and that's because of where it is located on the body. Whereas on the right, we have intertriginous dermatitis, which is poorly demarcated. Here is hand psoriasis on the left, again, well demarcated, dry and hyperkeratotic, whereas on the right, poorly demarcated erythema with fissuring. On the left, we have well-demarcated silvery plaques, and on the right, we have nonspecific asteatosis. So it's important not only to look at the clinical morphology, but also the anatomic sites of involvement, because that can give you some really helpful clues. The presence of typical psoriasiform nail changes is very helpful for a diagnosis of psoriasis when present. The umbilicus is also often overlooked, but frequently helpful area of involvement for psoriasis. Here's the intergluteal cleft, and you can see that it's involved in this patient with psoriasis, although of course you can get dermatitis in this area as well, particularly irritant dermatitis. Involvement of the scalp may be a clue for psoriasis, as in the case of psoriasis, although certainly the scalp can be involved with dermatitis too, particularly if the patient has, let's say, allergic contact dermatitis against their hair, dye, or shampoo. Involvement around the eyelids is very characteristic for atopic dermatitis, particularly when there are so-called allergic shyness. Dryness of the nipple may be a sign of dermatitis, whereas if there is involvement of surgical scars or areas of minor trauma to the skin, that might be suggestive of capillarization and psoriasis. And then, of course, patient history is always important. Don't forget to ask patients about associated conditions such as asthma or seasonal allergies for atopy, which would suggest atopic dermatitis, or inflammatory arthritis, which might be suggestive of psoriatic arthritis and therefore psoriasis. If the patient has a history of impetiginization, that might favor dermatitis as well, because in psoriasis, there's upregulation of antimicrobial peptides, which actually helps to prevent impetiginization in patients with psoriasis. Certainly, if there's a family history, that could be helpful. And also make sure to ask patients about inciting triggers. For example, if they had a recent strep infection preceding the development of their rash, it could be guttate psoriasis, or if they've recently taken a medication that's implicated in one or the other. In patients where the clinical diagnosis isn't clear-cut, sometimes a biopsy is necessary, and there can be some histopathologic clues that can be very helpful. So on the left, we have psoriasis. You can see that there's regular acanthosis, where the reedy ridges seem to kind of line up along the bottom. We see hypogranulosis with loss of the granular layer, maybe some thinning of the suprapapillary plates, and then importantly, we have confluent parakeratosis and also neutrophils in the stratum corneum. And these features are really pretty suggestive of psoriasis. Whereas on the right, we have some mild epidermal acanthosis, but it's more undulating rather than elongated reedy ridges. And then we also have some spongiosis, some space between the keratinocytes. We have a preserved granular layer, and we don't really have any parakeratosis. And when you look at the superficial dermis, you can see that there's mixed inflammation with quite a lot of eosinophils. So these are fairly typical presentations of the histopathology of psoriasis and eczematous dermatitis, respectively. A useful histopathologic feature to support dermatitis is the presence of Langerhans cell collections in the epidermis, which is often correlated with contact dermatitis. On the left is a pretty typical example of psoriasis from the scalp, whereas on the right we have very mild epidermal acanthosis with undulation, but you'll note that there is an intracorneal pustule, and this was actually a patient with guttate psoriasis. And here's a skin biopsy with the dreaded psoriasiform dermatitis. So some features of dermatitis, some features of psoriasis, and we see this commonly in the setting of palmoplanta biopsies or intertriginous biopsies, for example, where you can see spongiosis, loss of the granular layer, but it's not necessarily specific to the process. So what happens if the clinical and histopathologic clues are not definitive for either psoriasis or eczema? Well, now we have a few new tools that help us look at the molecular pathways involved, which can help to differentiate these two from each other. Here's a figure from a basic science paper from about 10 years ago that basically just proves the concept that you can differentiate different inflammatory skin diseases based on their cytokine profiles. The authors of this study noticed that IL-36 gamma, which is a marker of Th17 immunity, was markedly elevated in psoriasis compared to other inflammatory skin conditions. And so they tested the gene expression profiles on the top here, but also immunohistochemistry on the bottom, and they did show differential expression between psoriasis and the other inflammatory skin diseases tested. So let's take a closer look at the immunohistochemistry of IL-36 gamma. And on the top we have psoriasis, and on the right-hand side, we have the IL-36 expression shown in red. And you can see that there's strong and diffuse expression in the upper part of the epidermis, which is where we would expect it to be. Whereas in eczema, on the lower right, it's essentially negative. So Dr. Jeffrey North and colleagues at University of California, San Francisco took this observation and ran with it. And what they found was that of all the different markers they tested, IL-36 was one of the best at differentiating psoriasis from spongiotic dermatitis. And again, you can see that there's strong and diffuse expression of IL-36 gamma in psoriasis in the upper right-hand panel compared to spongiotic dermatitis in the lower right-hand panel. So that group took this a step further and looked at spongiotic psoriasiform dermatitis on the top and found a case that was IL-36 negative. Then in the middle, we've got SIBO psoriasis, which shows that the IL-36 was positive, which is in line with our concept of it being a Th17-mediated process. And then same with the bottom, where we've got TNF-alpha-associated inflammatory dermatosis. This is usually Th17-mediated, and accordingly, the IL-36 gamma immunohistochemistry is positive. This study looked at some mimics of psoriasis, Pityriasis rosea and Pityriasis lichenoides, and you can see that these entities are negative by IL-36 immunohistochemistry staining compared to the positive control of psoriasis on the top. Another group tackled the challenging issue of palmoplantar psoriasis versus eczema, and they found that the IL-36 gamma IHC expression was statistically significantly different between the two groups. And in fact, the IL-36 staining profile was a better predictor than any of the other histopathologic features that we've discussed previously. So after reading all this exciting literature, our group decided to develop IL-36 gamma immunohistochemistry as well. We started off by looking at psoriasis versus dermatitis, clinically and histopathologically clear-cut cases. And not surprisingly, the performance was really good. But that isn't really what the usual clinical question is. Usually it's when patients have overlapping features. And so what we did was we took cases of histopathology that were read out as psoriasiform dermatitis, so having features of both, but then reviewed the charts of the patients and included patients who had compelling reasons to either be classified as psoriasis or dermatitis clinically. So that would be some of those clinical clues we talked about earlier. And what we found is that even in this more challenging situation, there was still a really pretty good predictive power of IL-36 gamma in predicting psoriasis over dermatitis. So maybe this is sounding a bit too good to be true, and I would add that there are some caveats. So number one, is that the cytokines are promiscuous, so they are involved in more than one pathway generally, and this is true for IL-36 gamma as well. So although it's a strong marker of Th17 immunity, it also is involved in the innate immunity, and so it can be positive in the setting of tinea and impetigo, for example. Also, right now, there's insufficient data to support its use for predicting therapeutic response to certain biologics, even though it's intuitive that certain biologics targeting that pathway that's demonstrated with the immunohistochemistry would make sense. This has not been demonstrated convincingly in the literature to date. And then also there's insufficient data to indicate that it's useful for estimating disease activity or severity. So now let's take the special case of generalized erythroderma, which can be caused by multiple different inflammatory dermatoses, but that can sometimes be challenging to separate out clinically. So here there was a cohort of patients with generalized erythroderma attributable to multiple different inflammatory dermatoses. And first, IL-36 immunohistochemistry did help to sort out which cases were attributable to Th17-mediated processes, such as psoriasis or PRP, versus spongiotic dermatitis, where it was negative. But then the authors decided to also look at a marker of Th2 immunity. And so they looked at IL-13 RNA in situ hybridization. And positivity is shown by small dots in brown. And you can see that the IL-13 was negative in psoriasis and PRP, but positive in spongiotic dermatitis. So that's additional tissue-based evidence of the diagnosis in erythroderma. So these are some exciting tissue-based clinical tests to help differentiate psoriasis from eczema. Let's talk about some other future clinical tools as well that may be part of our armamentarium in the future. So this is another busy slide, but on the left you can see different collection methods to assess the cytokine profile in inflammatory dermatoses. We've talked about skin biopsy, but also you can look at serum profiling. And of great interest right now is minimally invasive skin profiling, as with tape stripping or curettage, for example. And then you can do your molecular test of choice, which can then help to potentially guide biologic therapy selection. And so here's an example of a technology that's being developed where you can insert tape stripping or even tissue sections into the device, and it can differentiate between the cytokine profile of psoriasis or eczema, and a future version of it may also be able to differentiate mycosis fungoides as well. So in summary, it's important to try to differentiate psoriasis from eczema in patients who have overlapping features. Now, in some cases, it may not be possible because patients may truly have an overlap of the two. However, wherever possible, try to use available clues, whether they be clinical or histopathologic, or maybe even molecular, to see if we can predict which inflammatory pathways may be involved so that we can appropriately select the best treatment for the patients. So with that, I'd like to thank you for your attention, and please don't hesitate to reach out if you have any comments or questions. Thank you.